The content provided in this podcast is for informational and educational purposes only and is not intended as medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
Is it my story, your story, his story, her story, Jane's story, Joe's story? Is it just an allegory? The show's about to start and we still don't have a name for it. Bop, 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 bop. It's a long story.
Aging and cystic fibrosis are words you don't always hear in the same sentence, but on this podcast, you'll hear them all the time, with relevant discussions and unexpected explorations wherever this podcast might take us.
So many people with CF are living longer thanks to modulators and medical advances. We thought it was time to get into some real conversations with expert guests and people from all walks of CF about what living longer with CF means, the good and the not so good.
I'm Dr. Ahmet Uluer.
And I'm Lauren Harvey.
I'm a medicine and pediatric trained pulmonologist and director of an adult CF center at a Harvard-affiliated hospital right here in Boston.
And I've had CF all my life and was recently diagnosed with CF-related diabetes. I am committed to creating a supportive space for those with CF and their loved ones.
I will bring the medical expertise and provider perspective.
I bring the real-life CF experience.
And together we bring you It's a Lung Story, a monthly podcast about aging with cystic fibrosis, where we take a little time to tell a lung story.
It's a long story.
It's a long story.
Well done, Andrea. Welcome to episode 7, and I'm Ahmet Uluer, and I'm once again joined by our intrepid producer who loves to skip dinner and eat dessert first, Andrea Becker.
That's right. It's the only way to go.
You know, I always have trouble remembering like how to spell dessert or desert, and I remember my friend telling me once that you can spell dessert with 2 S's because you always want more and you don't want more deserts. I don't know if that helps you. Does that help you with that?
Honorable mention is people who talk about getting stranded on a desert island or a desert island instead of a deserted island.
Yeah. Well,
Yeah.
we like to start by teasing each other, and I know that Andrea does love to eat dessert first, and and that's, I think, a great way to be. Also, I want to acknowledge that our other co-host, Lauren Harvey, is not here with us, and she's out on assignment because we do that. But she is out, and she is going to be telling us about her adventures when she comes back, and we won't spoil any of the great news that she's going to come back with.
We don't know. We don't know what her assignment is.
So on that note, I was just going to talk about how hot it is. I know that we are burning, and I was with our next guest, who we're going to introduce in just a minute, in Italy at the European CF concert and at the CF conference, the European CF conference, and where we were also in a heat dome, just like we're in a heat dome right now. I don't know if, and I'm sure we'll text a little bit about that, but while we were in the heat dome, and I'm sure we'll talk about this too, we were eating delicious food. And I was texting a friend of mine saying that this country is killing me, and this delicious country is killing me. And I don't know how many pizzas I ate and how many just amazing pasta dishes I ate, but it was just incredible. And I love it that the European CF conference gets to go to some really great places. I know, Andrea, I wish you were with us.
I was just trying to think of a way to say, like, maybe I could have been there to help you eat that food.
I know.
In reverse order, dessert first.
Well, we're lucky we have the North End in Boston.
Yeah, not the same.
So I guess we'll move on. And I'd like to introduce our 2 guests who are going to enlighten us on a very important topic today, and it's on cancer and cystic fibrosis. And I will start with Steve Freedman, who is director of the Pancreas Center at Beth Israel Deaconess Medical Center. He is the chief of the Division of Translational Research and professor of medicine at Harvard Medical School, and so much more, including being a true Renaissance man. He's a drummer. He's an ice climber, which is crazy. I wish he wouldn't do that. Cold plunger, a cook, and I learned something new about him every day, and a doctor you want in your corner when things go south. Hello, Professor.
Pleasure being here. Thank you for inviting me.
No, we are grateful for that. And I did want to make sure you do ice climb, right?
Rock and ice climb, equestrian, show jumper, hunter.
You know
Yeah,
what? I am not going to believe the equestrian jumper. Seriously?
yeah.
Oh my God.
Everyone knew my horse at Myopia Hunt Club in Hamilton, Massachusetts, Bandit. No one knew who I was. They would just, say hi to the horse. And I'm like, hey, I'm sitting up here on the horse here. You can say my name if you want. And they're like, no.
That's the way it goes with dogs, too. You know everybody's dog's name, but you never ask what their name is.
Next, I'd like to introduce Chelsea Lau, who is entering her third year as a hematology oncology fellow at Northwestern's Robert H. Lurie Comprehensive Care Center and currently receives funding from an NIH T32 grant, although I just found out that she is not receiving funding from that T32 grant. She's a physician who completed her residency at the University of Virginia and was actually planning on going into pulmonary medicine because her desire was to take care of people with CF. But she's fulfilling that right now, again, not by being a pulmonologist, but by going into oncology and now bringing her expertise to helping people with CF conquer cancer. Thanks so much, Chelsea.
Thank you.
And I wanted to say that we were fortunate enough to meet Chelsea at our first annual, so this is a plug for one of our conferences, our first annual Pat Nash Fellows Program, sponsored by CFRI and also supported and attended by the CF Foundation, where she joined 15 other fellows from all disciplines of medicine in the singular goal of making life better for those growing older with CF. So Chelsea, thank you for bringing your expertise here. And it was really great that you are one of our fellows.
Yeah, it was such a fantastic opportunity. Really excited to be a part of the fellowship and stoked to be here. Got to meet Dr. Uluer and Dr. Freedman there, and they're a couple of my favorite people. So always happy to hang out with them.
That's so great. By the way, I used the word stoked in our first podcast. So if you want to go back and listen to it, I can say that word too. It's cool.
You're so cool.
There are many things people with CF worry about. So we're going to get started. And even with the new modulator treatments, for those who are eligible, people with CF are always wondering when the other shoe will drop. And something that I often say because it is a comment that I frequently hear from people with CF. And getting or receiving the diagnosis of cancer is one of them. So we know that there's increased risk for people with CF getting cancer, but Steve, I want to talk about your observations since this is something that was published in 1995, but not necessarily something that people talked about. So I wanted to ask you what cancers are increased and, what should we be looking out for?
Yeah, I think the main focus has been on the GI tract cancers. And if you look at that original publications, that was their focus. And although it's still uncommon, there's definitely increased risk of colon and rectal cancer. Looks like a little bit increased risk of pancreatic cancer, perhaps some involvement of the esophagus. And, it used to not be much of an issue, but now that our patients, fortunately, are living a lot longer, we're starting to see the cancer risk come through here. And this is why we're all focused on what are appropriate screening procedures to do. For example, colonoscopy being one of the main ones now.
Thank you so much for that. And that article, for those who are interested, is a New England Journal of Medicine article from February 23rd, 1995. And the first author is Joseph Neglia. What other organs are involved too? And Chelsea, maybe I'll direct this to you. In addition to the GI, which is what we're focused on, and that's where the big signals are. But should we be thinking about other cancers?
So we can talk about screening maybe later. I think that's sort of a separate issue in terms of where we have data, where we're seeing increased rates of malignancies or higher than you would expect in a given population. As Dr. Freedman mentioned, the big ones is really the colorectal, pancreatic, but liver cancer is another kind of what we call GI or gastrointestinal cancer, and that's one where we do see a little bit of an increased risk as well. There's also some reproductive organ cancers that may have an increased risk. Again, the data is not super robust here, but maybe testicular, maybe cervical. And then more recently, breast cancer is coming into view as, is this something that is seen at a higher rate in patients with CF? And I think that we have some data there, but we need more. And as Dr. Freedman said, some of that is going to happen as we follow patients as they continue to have longer lifespans, as we get better and better at treating CF. So the older you are, the higher your risk of cancer in general. And so that's, I think, when we're going to get more of this data.
Right. There's like so many things out there that can confound some of these observations. So, and we're going to get into that a little bit. But one thing is that, why CF? And so we think that, perhaps it is directly related to the gene and the protein, the cystic fibrosis transmembrane conductance regular gene or protein. And when we've talked in the past, you mentioned CFTR, which is what we'll call it from now going forward. You classified it as perhaps a tumor suppressor gene. Can you explain what that means and, what makes CFTR one?
Yeah. So there's two kind of types of genes that we think about when it comes to increasing your risk for cancer or making cancer grow. So there's tumor suppressor, which is, you can kind of think about it as like a brake. So when it's functioning appropriately, the cancer car is not moving anywhere. You've got your foot on the brake, it can't go forward, right? And then there's also an oncogene, which is like the gas pedal. So like as long as you don't put your foot on the gas pedal, car's also not going to move forward. With CFTR, it's more like a brake. So when it's functioning normally, a lot of the stuff that it does helps to prevent the development of tumors. And there's actually more than one mechanism by which it does that. We're learning a lot more about it, but that's kind of it. When it's functioning the way that it's supposed to function, it helps prevent cells from forgetting how to do their job. It helps prevent cells from changing what they look like to become more dangerous. And it also helps to maintain what we call a microenvironment. So helps to kind of keep things running smoothly. So those are the kind of three mechanisms that it's involved in suppressing the formation of tumors.
Yeah, and I could tell that you wanted to totally geek out and start coming up with like the different pathways and like using these acronyms that were going to confuse all of us. But I'm glad you didn't. But I mean, explain that like that. The cancer, you mean, can look different and evade, detection by the body and by its own, sort of immune system. So is that what leads to like maybe metastatic disease, like what we talk about when we say things kind of spread from beyond that one organ?
Yeah, so there's kind of two concepts there. I'm going to focus on the metastatic concept first. So metastatic just means cancer has to start somewhere, right? So when we talk about the organ that it's in, that's where it started. But as cancer progresses, and we all see these cases, unfortunately, a lot of us know people who've had cancer, and we hear that word metastasis, or we hear how oncologists often describe it, which is like stage 4 advanced cancer. And so that's when cancer goes from where it starts and it ends up someplace else. And to do that, the cells that make up the cancer have to change, because normal cells don't just go on safari throughout the body. That's not a normal thing for a cell to do. So CFTR is important in preventing a cell from changing what it looks like. So like every cell that has a job is specialized exactly for that job. And when it stops looking like that, it can get slippery and it can move around the body. And so there's a couple of different ways that CFTR can make that happen. One is if there's an injury to a cell or an injury to a structure, CFTR helps to make sure that as healing happens, that whatever ends up there looks like it was supposed to look before. And if CFTR isn't functioning, then it might start to change. And then the other way is an active process where it actually takes on characteristics that make it more likely to spread. And so those two things are both implicated with CFTR.
Now, before I just switch gears from that, there was an article I was reading about how people who don't have CF, but who have tumors that just happen to get a mutation in CFTR, that would lead to that cancer being more aggressive. Is this like sort of what you're describing in that?
Yeah. So I'm going to say these words. You can forget them immediately, but it's the specific term for what it does is the epithelial to mesenchymal transition.
Mhm.
All that means is epithelial is like, these are cells that have a job or doing what they're supposed to do. And mesenchymal is these cells are slippery, squishy, it can go anywhere.
Yeah.
And CFTR is really important in preventing that from happening. And so if you don't have CF, but you have a mutation in CFTR and you have a cancer, you're more likely to see that process happen.
Okay. No, thanks for explaining. I think that analogy really works well, and then how it becomes so slippery like that.
Can I jump
Yes,
in?
I want you to. I
To,
was just going to direct it to
one
you.
little part of that.
Yeah.
I'm also trying not to be geeky, but it's hard
It's
with
hard.
Dr. Lau
It's so
around,
hard.
especially not to feel geeky and go. But if as kind of proof of concept that if you have some defect in CFTR, that can predispose to cancers, is this great paper in Proceedings National Academy of Sciences a few years ago that looked at carriers. So carriers, you have kind of half, 50% of the defect here, not overt cystic fibrosis necessarily. And if you look at carriers, they have an intermediate risk of cancer. So if you had no increased risk, if you have normal CFTR, and CF itself, full-blown risk, and carriers are in the middle. And we're seeing, unfortunately, parents, and I'm actually doing a large study now looking at why is it, and all of you see this in the news nonstop, why is it younger and younger people presenting with cancer? And we're actually looking to see whether or not, in part, in addition to maybe diet and other factors, are they carriers? Especially people with colon cancer presenting in their early 30s in the, quote, healthy general population, unquote.
Yeah.
And we're already finding it looks like an increased signal.
So are you recommending that our patients and their family members also go through screening, maybe earlier than what's recommended?
Yeah, there's no clear published data on that. Our whole genetics group at Beth Israel, it's now starting to be Dana-Farber Cancer Institute, are now sending their patients to me who are screened because they have a strong family history of multiple cancers, and they happen on a screen to come up being a CF carrier. So they're now referred to me, and I'm doing a little more aggressive earlier onset colonoscopy. We don't have data right now, but if you look at that Proceedings National Academy of Science or PNAS paper, carriers are at intermediate risk, and that would fit with the biology of this protein. As Dr. Lau was saying, it's a tumor suppressor, so you partially just took brakes off the system.
Yeah. You know what? I do think that this is probably a good place to actually talk about screening. And, because one thing I'll just actually first say is that, Andrea, we just had 3 people with lung transplant join us in addition to Andrea to our last podcast. And, cancer screening and, has been very well known is a big part of the post-transplant care. But what makes Andrea and people who've been transplanted higher risk for cancer?
Transplant, and particularly lung transplant, as a lot of people listening to this are going to know, you have to make sure that the immune system is on a leash, right? You have to make sure that the immune system is going to protect you from infection, but not get so excited that it starts to attack your graft, so your transplanted organ. And lung transplants in particular are at higher risk for this. And so a lot of times these patients will end up on higher doses of immune suppressing medication. And none of that is going to be news, I'm sure, to most people listening to this podcast. But immune suppression, your immune system is really important in protecting you from the development of cancer. So this is actually something that Dr. Uluer mentioned earlier, which is cancer becomes invisible to the immune system, and that's how it grows, right? And so if you suppress the immune system so it's not as good at seeing cancer, then cancer is more likely to get the opportunity to get a foothold and to start growing. Because we are constantly, all the time in our daily lives, with CF or without CF, accumulating tiny, small changes in our genes and various cells in our body. Our immune systems are just really good at cleaning things up before they can cause a problem. And so not only is a patient with cystic fibrosis at higher risk because of some things we already talked about with CFTR, but if you add immune suppression into that mix, then you're also suppressing one of our body's mechanisms for preventing cancer. So you're taking a couple of different breaks off.
knock on wood, I have not had cancer. I've had everything else, but, I also know people who 1 year out get lymphoma. What is it about lymphoma versus other cancers or these variations of lymphoma that makes it,
Uh,
so
yeah.
popular?
So the one that we worry about the most is something actually called post-transplant lymphoproliferative disorder, or PTLD. It's a kind of lymphoma that we really only see in transplant patients. And it's not just CF, it's not just transplant, it's also a virus. So there's a particular virus called Epstein-Barr, which is mono. So most of the people in the world have had it at some point. And for most people, it means that you get a sore throat for a week and you feel pretty tired for a little while, and maybe there's some worries about your spleen for a second, but then you're fine. The issue is that it can hang out in the body for a long time. And again, our immune system is being suppressed to protect something in our body, like a lung graft. It can wake up and it can start to cause problems. And one of the places that it causes problems is in the lymph nodes, and it can cause this lymphoma called PTLD. And there's a couple of other lymphomas that are also related to viruses that you could be at increased risk for when your immune system isn't working as well. And then the lymph system is a part of your immune system, so you're altering it with immune suppression. So I think that the biggest factor is probably going to end up in these circumstances going to be like infections or chronic infections that aren't controlled anymore, like we see with the PTLD or the post-transplant lymphoproliferative disorder.
That's a great answer because, Epstein-Barr, that's one of the reasons why Andrea and other transplant patients, your transplant team will check whether you've been exposed to EBV, and there's other viruses as well. This is the reason why they do it. And then they monitor that before and after, and your donor and what their status is as far as exposure. But let's talk about screening really quick, because the CF Foundation, recommendation is that we do a colonoscopy starting at age 40. And if you don't have any polyps, you did it for 5 years. I'm going to have you guys go into details about this. And for post-organ transplant, it is starting at age 30 or within 2 years of your transplant. So that's the recommendation from CF Foundation. But I want you to comment on that, Steve, and sort of how and why we're deviating from that recommendation.
So if you look at the original paper that came out of University of Minnesota, they took individuals with cystic fibrosis, 0 symptoms, no blood in the stool, not a trigger that they should have in colonoscopy, and they took them at age 40 and did colonoscopy on all of them. And what they found was that at least half of those individuals had significant polyps called adenomas. A number of them had what we call high-grade or high-risk features. And there was, I think it was like 4% of individuals or something like that, that actually had cancer of the colon on that initial screening colonoscopy. That was age 40. The whole name of this game, so to speak, is we want to find things as a polyp. I can remove polyps, takes a few extra seconds, that's painless, and that's how we prevent someone from going on to colon or rectal cancer. So if you're already finding cancer at age 40, it's definitely too late. We start screening, and I think it's to his vision and others in our group here, we start screening in your 30s. And I don't know if Ahmet's seen the report from an individual he'll see next week. And, he's 37 and he had a significant polyp in there. If he waited till age 40, probably would have been a cancer in his colon. I just talked with him today on his polyp results from Monday. So 40 is too late. I think, and I've said this to the CF Foundation, they understand this. I think we'll start probably moving this up, especially as people can tolerate colonoscopies a lot better because of Trikafta. As Andrea knows, once you start having significant lung disease, we start getting much more nervous that we will cause a complication when we do colonoscopy because we have to put you to sleep. You're still breathing on your own. But if you're already having significant especially lung issues, that can be a problem and put you at increased risk, which is why I launched a few years ago with Sarah Jane Schwarzenberg and Christine Hacham being the PI under us, mentoring her, NICE CF, looking at whether or not a modified Cologuard with a microscopic test of blood together would help predict no polyps at a colonoscopy, especially for people that are at higher risk to undergo sedation for colonoscopy procedure, or they're on blood thinners and you can't take them off for that.
One of the best emails I can get in a day, and I can just picture Steve writing this email and like just giving me a virtual high five and maybe even scratching a notch in the wall of the endoscopy unit saying another person saved from cancer.
It's true.
And I just, I mean, this is really fantastic. Everyone gets one of those emails when that happens. You find the polyp and you're like, we just prevented cancer. And I think it just fills us with joy. And also that person obviously is grateful. So thanks for that.
I'll just put a plug in because like this gentleman on Monday, he's seeing you next week, Ahmet, he'll tell you this too. He said, but the procedure was awesome. I was high as a kite and afterwards I was great. But he had minimal lung involvement. So FEV1 in the 70s. But but still there always is a safety concern. And the more progressive your lung disease, the more concerned we get.
I was just going to say that, one of the reasons we're doing this podcast is because I listen to a lot of podcasts, and during the pandemic, all I was listening to was Conan Needs a Friend. And Conan loves doing colonoscopies. I think he would do one like every 6 months if he had to. He loves that. He loves his sedation, and he talks about it all the time. He should, and I think he is also a spokesman for colonoscopies.
I just want to say, just for those people who are listening who might have significant lung involvement, but there are ways, right, Ahmet, to, get some answers.
CT colonography, it gives us a good look at the colon. Anything over like 7 millimeters for polyp you can see. And it's a little bit uncomfortable, but it's a way to see the colon in someone who's very high risk for undergoing sedation for the procedure. We do want to stay ahead of screening, and I can, without spilling all the beans, will be presented in North American CF meeting in October, November, whenever we're there. It looks like being on a CFTR modulator like Trikafta does not decrease your risk of getting colorectal cancer. At least if we look at what we're finding in colonoscopy, being on a modulator is not having a big difference.
That's really interesting. One of the things that, as Chelsea, you were talking about, is that CFTR does affect some of those pathways. And if it's absent, those things that make things slippery can happen.
For sure.
Steve, do you think that it's just too soon? And it's certainly, you're not seeing that it's increasing risk. You're just saying there's no change. But do you think that maybe we just haven't given it enough time yet?
Great question. I do have an NIH R01 grant with AP Naren on this from Cedars-Sinai, California, trying to look at why this is. For some reason, the GI tract does not respond like the lungs do when it comes to modulating CFTR. Probably a lot of reasons for that. But I'd say don't feel like you can blow off all screening because you're on a highly effective modulator. I guess I'll leave it at that. I was about to get geeky and get into what we're showing in my lab about why cancers develop like this and how it relates to being an infant.
We're going to get to that. Chelsea, did you want to add something to that?
So we talked a little bit about this. I mentioned something called the microenvironment earlier. And it's a little bit of a geeky term, but essentially it's what is happening immediately around a tumor. We also sometimes call it a tumor microenvironment. And CFTR, when it's not functioning right, it changes that microenvironment. And it can also change something called the microbiota. So that's like the bacteria that you have in your gut that we need, right? Like we all have it, we have to have it. It's different in patients who have CF. And Dr. Freedman, correct me if I'm wrong, but it doesn't really improve or change closer to what we would expect it to be even with CFTR modulator use.
Yep.
And that microbiota is very important for inflammation in the gut. And that inflammation is what changes the microenvironment. So it's a cascade of things that get set into motion very, very early. Like there's data on microbiota starting at birth all the way through the rest of your life. So I think there may be something to it's still kind of early, because the patients that we're seeing who are being diagnosed with cancer, with colorectal cancer, were likely not on modulators in like early childhood and childhood. And we know more and more in cancer that these things that are happening to our gut, to our body in early childhood and childhood set in motion a cascade of effects that goes throughout our whole life. And so it's possible that those who are able to start on CFTR modulators and may be able to have something closer to a normal microbiota or gut-like bacteria population earlier in life won't have that kind of inflammation, or it might not develop to the same extent. But it's because there's so many layers to how that happens. Just turning CFTR back on is not going to affect those earlier steps.
Okay. And it is hard to move on to other subjects. I'm going to ask one more
Sorry.
thing. No, it's like, because this is so interesting. We can obviously do this for hours, and Andrea is like looking at the time. But and I have also questions that Andrea wants to ask
No.
as well. But Dr. Freedman, Steve, you're a pancreas expert, world's foremost pancreas expert. So I was telling somebody, I'm speaking out of line, that their acute chronic pancreatitis got better. They're the parent, let's say, of somebody with CF, and that's how they present it. And now CFTR modulators have almost eliminated their pancreatitis. So my thought was pancreatitis can lead increased cancer risk. So did the modulators help that person? Would you say in that particular scenario that's the case? Or maybe I'll amend my statement to them next time I see them.
It can definitely help pancreatitis being on modulators. There's data, if you have any kind of CFTR defect, it can help. And we've published, me, Drew Borowitz, a few other people, that in retrospect, ivacaftor resulted in complete cessation of recurrent episodes of pancreatitis. If your question is, and can I get a touch geeky, back to what Chelsea was saying on the microenvironment? So cancers, this as a GI person, we're limited on our light bulb here. We're not the brightest bulbs on the planet. So what cancer is, two things. One is it's just a cell that becomes immortal, becomes just like when you're an egg. I mean, if you think about it, you fertilize an egg, and an egg all of a sudden after 9 months becomes, a person popping out of the womb, right? So it goes from a single cell to uncontrolled growth that then all of a sudden differentiates. The cells get controlled. Chelsea's like, do we have to be on with him?
Yeah.
It gets totally controlled and forms all these organs, and then you're a person, right? And what's cancer? You now switch back, and all of a sudden those cells take off the brakes. They become undifferentiated, is what we call it. They just have uncontrolled growth, and they become slippery, as Chelsea said, and then they just go crazy. The second part to that is that forgive me on the political side, but for example, people in Washington currently love an inflammatory environment. That's how they make themselves very public. And cancers love the same thing. They love to incite everything around them. And if you are in an inflamed environment, they just go nuts and grow and have a great time, so to speak. So we have those two factors.
Yeah.
In my lab, we've now looked at those signals that cause cells to go from a single cell, become controlled. And we've now put cancers in our mice with CF, or carrier mice and normal mice, and we can recapitulate all this accelerated growth if you have a CF gene defect. And what we find is that it actually does what Mother Nature does, but in reverse to an egg. And so now it causes those cells, those cancer cells, they shut off the signals that shut off inflammation. these resolvins, we're going to talk about diet probably. These omega-3 fats form these metabolites that normally resolve or shut off inflammation. What do tumors do? They're smart. They actually shut off that pathway. So now uncontrolled inflammation won't terminate. Perfect environment for them. And by the way, those resolvins that shut off inflammation normally, they also maintain normal cell growth. So now you've lost that. And so you have immortal cells that's driving a very inflamed environment, and that's cancer. And what we're seeing in our mice, not published yet, but soon, is that these cancers in the setting of a CF gene mutation, they just shut off this resolving pathway here.
First of all, that is such interesting stuff, but I can't help but say this, just like a politician, you didn't answer my question. I said it was a yes or no. It was a yes or no question. Andrea, let's go into the diet question. But can you I know that you wanted to ask that question, and that's something obviously you're looking at all the ways that we can reduce our risk. And Dr. Freedman, Steve talked about resolvins and omega-3s. So, but why don't you ask your question eloquently like you were before?
Well, now that you said that,
Oh.
I'm gonna like uneloquently ask it. The question is, there's so much out there on the webinet about, what to eat and not eat and drink and not drink. We have, as CF patients, we have all these other, silos, for different aspects of CF to pay attention to what we eat. Looking at well, if I eat a lot of fruit and veg, it's going to up my reflux, but is it going to push down my cancer risk? And I guess the question is if I'm on the internet and looking around and seeing kind of thematically similar stuff, is it different for someone with CF? What we should be focusing on, or is it similar to the general population?
I've got to be careful here because I have a soapbox about this. Be careful about the internet. There are a lot of things that are on the internet, particularly around diet, particularly around cancer, that are overly restrictive. Things where we have data, where we know this actually helps in the general population. Avoiding smoked meats and particularly red meats is helpful. Avoiding nitrates, helpful. We know that reduces our risk, particularly of colorectal cancer. Things that might be harder, high fiber diets, particularly in childhood. So high fiber diets starting in childhood all the way through adulthood, those help with some of the stuff we've already mentioned here. So help with the gut bacteria that we have, help with gut inflammation. So making sure to eat good natural fiber sources, and avoiding things like constipation and severe, prolonged transit times. That's really hard in cystic fibrosis, right? That is not an easy ask. So that's where we know that could be helpful, but that has to be balanced with what is possible. And knowing that as much healthy, good soluble fiber sources as you're able to get, particularly with younger children, because that's going to set them up to have better gut function long term, which decreases the risk for cancer. And then there's things that are, again, true for everyone. Alcohol, particularly for women, we know is increasingly being thought of as a carcinogen. So avoiding alcohol or significantly decreasing alcohol intake, really important for preventing cancer. So those are things where we have really good data, right? And then we can get into things where the data isn't as clear. Well, it's not that the data isn't as clear. The data is very clear. Dr. Freedman's already talked about healthy fatty acids, things that help to make protective substances in the body. So eating healthy fats, the Mediterranean diet in general is a really good one for not only getting good fiber. It tends to be pretty fish and poultry heavy, so you avoid a lot of red meats, and then you also get a lot of these healthy fats. That's usually the diet that I say, if you guys are going to pick something, that includes a lot of the things that are good and avoids a lot of the things that are bad, except for the astronomical quantities of wine. So that would be kind of my thoughts there. But Dr. Freedman is a gastroenterologist who takes care of patients with CF, so I wanna leave some space here for that too.
By the way,
Small
in
space.
GI training, there's no nutrition education. Although this is
It
part of
is,
what I do.
yeah.
Yeah, I mean, I'll just build a little bit on that. That was perfect. Omega-3 fats, anti-inflammatory, anti-cancer. That's the cold water fish that Chelsea was mentioning. Omega-9 fats, canola oil, but especially olive oil, Mediterranean diet, very anti-inflammatory, anti-cancer. The omega-6 are the bad ones in the middle. Red meat, vegetable oils, like things fried in corn oil, they turn on inflammation. They turn on uncontrolled cell growth. So those are the ones to avoid. Uh, vitamin D, vitamin D3 has gotten a lot of press. That with or without fish oil supplement doesn't make a difference, not make a difference. In a subset of people, but not everyone. And we don't know about in CF, it seems to decrease your cancer risk. There was a paper that came out in the past month. I figured Ahmet would be on it if he's not on vitamin D. It actually prevented shortening of your telomeres,
Oh, yeah.
hence slowing biologic aging. Your telomeres, as we get older, gets shorter, and that's associated with aging. And if you can keep them long, it's the fountain of youth and vitamin D.
If you could just, for those of us in the back, tell us what a kelomer is.
A telomere is your ends of your chromosomes, your kind of end of your genes, so to speak.
Oh, okay.
And it's kind of like if you look at my hair, it's gray, fizzled at the end. Look at Chelsea, youthful, whatever, and perfect. And the same thing, my telomeres probably look like this. Chelsea's do not. But if you can keep them long and looking good, that's biologically looking healthy. So
So
can't hurt, can help.
I'm literally doing all those things. I haven't had a drink since my transplant. I don't eat red or meat or pork. And I eat very healthy. I cook my own food. I don't eat processed food. I mean, some things I have, like sometimes I have like a cookie. But have not had cancer yet.
And by the way, I know organic food is very expensive, but the food chain is loaded with antibiotics. I mean, that's how you fatten up chickens and cattle.
Well, I will say this. Here's my stance on organic food, and I'm not a doctor. I just want to caveat that. But I'm like, I'm going to take my chances with like the sprays and stuff because I feel like when you've had a couple hundred CT scans and radiation from all that, like if organic food's going to get me, I would be extremely surprised. So,
I'm glad that you said that because there are a lot of people who with CF, I mean, they're paying for drugs and other things. They don't have that excessive funds to, also pay for organic foods. But Chelsea will remember like that this is the telomeres is definitely something I love talking about. And this is something I like. I definitely like ruin a lot of dinners talking about telomeres. But as and that is another cancer risk. It's just that when you start losing those protective strands of chromosomes, the way that cells replicate becomes less and less efficient, right? And so, I mean, that's a big part of. So things that will improve that are, first of all, don't become a doctor because your
I know.
intern year, you lose more telomeres, than you would have like in 15, 20 years of your life if you didn't have that stress. But, I say this to doctors and obviously it's too late. So this is great. I wanted to also just make sure we don't neglect the other organs. We had a sexual and fertility health episode, and Raksha, Jane, and I both admitted that we've been ordering mammograms for patients because sometimes our patients just aren't going to see their PCPs. Is there anything that you would deviate, Chelsea, from other screening methods right now? I mean, pancreatic cancer, I know, Steve, we're not going to really probably get to talk about this, but we're screening at age 50. Maybe we should do that earlier. We're going to be discussing that in the future. But Chelsea, what other things would you alter screening from what the current guidelines are, if you would?
So we'll talk about breast for just a second. I think that that is going to become clearer as we have more information. Things that people should pay attention to for breast cancer screening. A, if you have not talked to your primary care doctor about breast cancer screening, you should do that, particularly if you're age 40 or higher. B, if you have a family member who has been diagnosed with breast cancer, because that is one of the biggest risk factors. And we know there have been very large epidemiological studies looking at CF carriers, that they are at higher risk for breast cancer. And so it is likely that if you have CF, that you probably have a family member somewhere with breast cancer. If you do, start screening 10 years before that. So that is something that you should talk to your primary care doctor about, because they might not always ask. They should, but they might not always ask. So if you have that in your history, we know that it's not just CFTR mutations. There's a lot of other things that go into causing an increased risk for breast cancer, and those can be cumulative. So if you have a relative who's had breast cancer, that places you at a higher risk. So you should talk to your doctor about that. Otherwise, we don't really have enough data to justify it. And I want to be careful about one of the other organs outside of breast cancer that I think about a lot. I'm in thoracic oncology right now. I do cancer in the lungs, which when I'm not talking to patients who have GI cancers and CF, thinking about the lungs. And one of the things that I was hoping to do with the Pat Nash program was to look into lung cancer screening for patients with CF, because there is the possibility, we just talked about how inflammation is a happy place for cancer, right? That when things are inflamed, cancer likes it there. And patients with cystic fibrosis have a lot of lung inflammation, get a lot of scarring. We know that as tissues heal, they're at increased risk for developing cancers. And so even if we haven't seen it yet, it's possible that we could see increased rates of lung cancer as patients get older in patients with CF. But lung biopsies are not totally benign. Low-dose CT scans for lung cancer may not pick up very much in a patient who has a lot of underlying lung disease, because they don't pick up enough detail. And we don't want to add to all of that radiation that Andrea was talking about, right? We don't want to add more doses of radiation if we don't need to.
Yeah.
So I think it's one of those things where we need to be looking, we need to be thinking about it in terms of, if somebody is getting a scan for another reason, there needs to be attention paid to things like nodules in the lungs that are growing. And if they are, we need to think about getting biopsies. If patients have family history of breast cancer, they need to be more aggressive about making sure that they get screened. But we don't have enough data right now to recommend broad changes in screening in those cancers.
No, that's perfect. I mean, there is this entity called non-CF bronchiectasis, which is the same kind of damage we see in CF, but when you don't have CF. And they are at increased risk of lung cancer. So we know that. But it is interesting, and it may be because, we are seeing now people getting older, but I've only diagnosed it once in somebody who, was smoking since they were 10 years old. But it is surprising to me, and maybe we're just not seeing it, or we're not picking it up, that we haven't picked up more of this. And but that's something important for us to continue to look at. But we are coming to the end of our hour here, and I did want to recap that, it is important to pay attention to your lifestyle. It is important to stay active and exercise. Important to watch your diet, but not crazy. Don't just watch everything on the internet and decide to do that. Listen to Chelsea and Steve, and make sure that you're, making the smart decisions that aren't bankrupting you, Andrea. But then also recognizing that, CFTR and cystic fibrosis would put you at increased risk. So thank you so much for, all of this great knowledge. There's so much more we can talk about, but I did want us to move over to the next section of our podcast. And it is called, What Does This Have to Do with Anything? Usually we have one guest and going through all 10 questions, but we're going to alternate you guys.
Yeah, 60 or so seconds on the clock. There's about 10 questions, but sometimes there's 11. And we're going to alternate. So it's technically like a lightning round, but take the time that you need. And at the end, we will let you know how many points you have. And then at some point in a few months, we'll add them up and see who won and send you an email.
Can you believe it? You're going to get an email, Chelsea or Steve. You might
So
get an email.
exciting.
You may not. All right. Are we ready? Chelsea, you
Let's
go
go.
first. Best way to cut a sandwich, diagonal or triangles?
Diagonal.
Which one tastes better?
Diagonal. What?
Wait, no, that goes over to Steve.
That was going to be for Steve. Sorry, Steve.
Triangles.
Triangle. That's my bad.
Yeah.
Because we just kept going. It was lightning round. Steve, so triangle you like better and you said and tastes better. Got it. So back to Chelsea. Scariest animal, wolf or spider?
Oh, spider. So depends on what kind of spider.
Okay. Good answer. Steve, if Hollywood made a medical drama about CF, what's the one mistake they would definitely get wrong?
Focusing on sputum too much.
Okay. Chelsea, is the pit realistic?
Yes.
Okay.
Yes.
Do you love it?
Oh my God, it's so good.
So good. I do too. Steve, true or false? Our co-host Lauren just got engaged.
I don't know. True, probably.
All right.
She's on an expedition.
She's on an assignment. Number 7, Chelsea, Pedro Pascal or Timothy Chalamet?
Oh, Pascal for sure.
Wow. I
Not
mean,
close.
that's pretty amazing.
You'd be surprised at how the answers are always
Yeah.
different, but extremely sure.
By the way, we're hoping to get Pedro on this podcast one of these days. All right, Steve, Marvel or DC?
They're both so good.
I know you're not gonna. You feel like
Marvel.
Gotta pick.
you feel like you're
Marvel.
offending like one group of your fans
Marvel.
out there
Yeah, I
on your
know.
social outlets.
Oy.
Gonna lose half your patience.
Chelsea, sweet or salty?
Salty.
Steve, flat or sparkling?
Sparkling.
Okay, good job. Andrea, are you going to count up those?
All right, hold on just a second. Let me just add this.
Did we
right
just
up
win
here.
$10,000 each?
60. You're coming in at 62,900.
Wow. Okay, that's pretty good.
Points, which is in relation. It's all about what it's in relation
And yet, someone
to.
did threaten us, and they may have gotten more points.
Yep.
Well, this was amazing. And now the last thing that we're asking you to do, you did hear our little jingle. So we're going to see if you could sing that last part of that song.
All right.
Chelsea,
It's a long story.
I like it.
Nice.
She didn't ray it. She read it. Good. All right, Steve.
I'm a drummer, but it's a long story.
Oh my God. Stick with drumming. No, I'm just kidding. I'm just kidding.
All I can tell you is that this is going to go viral when it goes viral, and you're going to be famous on the internet.
Can Chelsea and I get rid of our day job then afterwards? Is that?
Yep. The whole thing. We're all going to get rid of our day jobs.
Well, that's it. I hope this podcast resonated with you.
Until next time,
Get a little older.
live a little bolder. We are working hard to provide meaningful information to a deserving CF community, information you won't find anywhere else. If you'd like to help us grow, we'd greatly appreciate it if you would follow us on Apple Podcasts, Spotify, or wherever you get your podcasts, so you never miss an episode. Want to go all in? Leave us a rating and a review. It helps people find us and makes a big difference. If you found this episode helpful, please share it with a friend, family member, caregiver, or provider who might also want to hear it. This helps you, it helps them, and it helps us spread the word to those who need to hear it most. It's a Long Story is produced by me, Andrea Gavin Becker, and is hosted by Dr. Ahmet Uluer and Lauren Harvey. Additional editing and production support is provided by the team at Resonate Recordings. Until next time,
Get a little older.
Live a little bolder.